The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Okay, so next, I have a question for you. During her follow-up visit, a 33-year-old pre-gravid on her 9th week of gestation showed you her FBS results, and it turned out to be 99 milligrams per deciliter. So what is your complete diagnosis? So 99, is this significant? Based on our local guidelines, yes, it's significant. So ano ba ang pina-follow natin? So di ba ang first prenatal visit, kung hindi naman 24 to 28 weeks, we order FBS. So kapag ito yung mga value cutoff natin, at less than 92, that's normal. So kapag normal, you repeat it at 24 to 28 weeks. So again, bakit 24 to 28 weeks? Again, guys, placenta talaga ang may problem. Placenta ang nagpo-produce ng human placental lactogen. Okay? So that produces that is the hormone responsible for your GDM. So nagmamature siya, tumataas yung insulin resistance mo at 24 to 28 weeks because this is the time na enough na pinoproduce niya na HPL to resolve to insulin resistance. Therefore, nag-GDM na sila at 24 to 28 weeks. So dito nyo sila pinaka-makakatch. Alright? So yung patient natin, 99 siya. So considered siya to have GDM. So example, paano kung yung FBS nyo ay 129? So pag 129, na-reach na niya yung value enough for her to be labeled as overt. Okay, diabetes mellitus. It means na sobrang taas ng sugar niya, hindi mo lang masisisi sa placenta na probably baseline may diabetes talaga si mother. So this is our cutoff values for your GDM. Ayan. So greater than or equal to 192 for fasting. 1 hour plasma glucose is greater than or equal to 180. So second hour plasma glucose is greater than or equal to 153. So kapag ang second hour mo 153 GDM ka, alright? Dati 140, but we already adapted yung higher cutoff values. So overt DM ka naman if the fasting is greater than or equal to 126. So itong 75 gram OGTT, in case you don't know how we take this, first, we do fasting. We take the fasting blood sugar of the mother. We ask them to drink 75 grams ng glucose solution. We take the plasma glucose 1 hour after and 2 hours after. Doktora, what if po 205 yung first hour niya? Eh di overt po siya, doktora. Hindi. Overt ka lang if your value exceeds or is equal to 200 milligrams per deciliter on your second hour plasma glucose. Naget? Second hour yung tinitingnan natin for overt. Alright. Okay. So what is her complete diagnosis? So first we mentioned the AOG. The obstetric score. So she's gravid 1, para 0, pregnancy uteri, 9 weeks, age of gestation. So first trimester pa naman, so no need to label if not in labor or cephalic in labor, cephalic not in labor. And then because of her FBS results, we already label her as gestational diabetes mellitus, newly diagnosed. Kasi between 192 to less than 126. Alright? Yan. So kahit isa lang, and kahit yung FBS lang niya on initial visit, yun na yun. Pwede mo na siyang i-label as GDM. Alright, so other results. Pinakita niya sa'yo, may iba pa siyang lab results. Rubella IgG is non-reactive. Good ba to or bad? Actually, hindi naman bad, pero ibig sabihin, wala siyang immunoglobulin, wala siyang protection against rubella, non-reactive, okay? So kapag nakakita ka ng reactive rubella IgG, huwag mo i-refer sa residents mo na, ay doktora, may abnormal results. That's actually what we want, na may protection siya, may IgG siya against rubella. And her HBsAg result turned out to be reactive. Okay, so meron pala siyang hepatitis B infection. So upon probing, she was already diagnosed with hepatitis B infection 2 years ago. And naunahan ka na ng resident mo, nakita na pala niya to or na-elicit na niya to. So nagpagawa na siya ng hepatitis profile, and the result of the profile is as follows. All right. So because this patient has been infected with hepatitis B for longer than 6 months, 2 years ago pa siyang na-diagnose, we label her as a case of chronic infection. Okay? So doktor, hindi ko naman alam kung gaano na siya katagal infected with hepatitis B. We could look at the antibodies. Diba? IgM is for acute, a marker for acute infection. IgG, it's a rough marker na chronically infected na. Okay, matagal nang na-form yung antibodies na yun. So how do you interpret your hepatitis profile? Okay, so this is what you look at. So mas extended pa to actually, pero simply, para mas simple lang, ito yung mga important na makita. So your HBsAg, this corresponds to your surface antigen. So this is a marker for infection. If you have this, it means you're infected with hepatitis B. Your anti-HBs is diagnostic for immunity, either through vaccination or from natural infection. So it will not distinguish between the two. Pwede ba, doktora, na parehas silang reactive? Hindi. Dapat hindi parehas na reactive ang HBsAg at anti-HBs. Kung reactive ka sa HBsAg, dapat non-reactive ka dito and vice versa. Alright? So, ibig sabihin kasi ng may anti-HBs ka is you already cleared the infection. So, hindi ka dapat, kung mag-reactive ka dito sa anti-HBs, dapat non-reactive ka na sa HBsAg. Si anti-HBc, ito yung core. The C here stands for core. So, this only happens, this antibody, kaya siya anti, diba? Antibody, this only happens this is only produced as a result of natural infection, not through vaccination. All right? The HBe, your envelope, that's your E there, it's a marker for high viral replication. So E, ang mnemonic ko dito, E is infectivity. So if you have high viral replication, you will turn out to be reactive on HBe antigen. Okay? So it means you have high infectivity. There is detectable HBV DNA in your system. So si patient natin, siya ay infected, chronically infected. So wala siyang non-reactive siya for anti-HBs. So check naman to. Meron siyang antibodies na. So as a result of natural infection. So ibig sabihin, naturally infected siya. Yun yung source ng kanyang antibodies. Good for her, wala siyang HBeAg or HBe antigen. So meaning, meron siyang low infectivity. So the full diagnosis in terms of hepatitis for this patient is she has chronic hepatitis B infection with low infectivity. Okay, sorry, I failed to write B infection kasi may iba pang forms of hepatitis. What if mataas or reactive yung HBeAg mo? Then we change the diagnosis. Chronic hepatitis B infection with high infectivity. E is for infectivity. It's a marker for high viral replication. All right? So, ang full natin na diagnosis for this patient is G1P0, the AOG to 9 weeks, GDM newly diagnosed, and she also has chronic hep B infection with low infectivity. All right? Kasi meron siyang non-reactive HBeAg. Pero reactive yung HBsAg niya. Alright? That's 2 years ago, kaya siya chronic. Okay. So, since she has non-reactive rubella IgG, she is asking, baka doktora, pwede niyo naman akong bigyan ng protection? Baka pwede akong magpa-MMR vaccination. What will you tell her? Pwede ba siyang magpa-MMR vaccination? Okay. So, maraming vaccine. Kung makikita niyo yung Williams, may mahabang list doon ng vaccination. Pero I'm highlighting this kasi ito yung mga typically in-offer namin sa mga pregnant patients namin. Tdap, we offer this in 3 doses. No? So, the booster is every 10 years or once per pregnancy. And we offer this between 27 to 36 weeks. Why? This is to maximize passive antibody transfer, so passive immunization. So influenza, according to our local CTG, iba to sa Williams. Hindi ko na nga maalala yung sa Williams. Basta it should be given once a year. And if you happen to be pregnant between February to June, according to our local guidelines, this is the flu season, this is when we recommend your influenza vaccination. Pero kung ano ba, January or July, okay lang naman. Pwede ka pa rin naman magpa-influenza vaccination. And then another one that we recommend is your hepatitis B if still non-reactive to your anti-HBs. So we offer this to our patients. All right. So, ano sasabihin mo sa patient mo? So this may be given to you, but postpartum na, hindi during your pregnancy. Why? Because we don't give live attenuated vaccines during pregnancy. So ano yung mga examples ng mga live attenuated mo? MMR, varicella. Yung HPV, hindi to live attenuated, but the studies that are currently available do not support giving HPV vaccination to pregnant patients. So kapag halimbawa nag-HPV vaccine ka, tapos naging pregnant ka, magsa-stop yung dosing for your HPV vaccine. All right. So your patient, this is the same patient. She asked you, Doc, kailan po ang follow-up ko? So she's 9 weeks, tama ba dun sa example ko, sa scenario ko? So ito siya. Every 4 weeks until 28 weeks, every 2 weeks until 36 weeks, and weekly thereafter. So remember, after 36 weeks, term na siya, 37 weeks. So weekly mo nang i-assess yung cervix niya at this point. Alright? I-IE mo na siya. So kailan ka nag-IE? Okay, side question. Kailan ka nag-IE? So baseline, nag-IE, speculum examination tayo during first visit. Sa mga succeeding visits, kapag may indication lang. Pag halimbawa, nagko-complain siya ng contractions, nagko-complain siya ng discharge, but otherwise, usually week ito na. Dito sa weekly thereafter na kami nag-IE ng patient. Alright? Para hindi naman sila IE ng IE for each prenatal. Alright, so next question. You have a 26-year-old G2P22002 patient, so hindi pregnant yung patient na to, who is desirous of another pregnancy. Her firstborn was born term but with myelomeningocele. So this baby has a spinal cord defect, a neural tube defect. So how would you advise this patient? Okay, so ang important dito na gusto ko lang i-highlight is the need for folic acid supplementation. So to all ladies out there, or if you are a partner na gusto mong magbuntis or been trying to get pregnant, please take folic acid. All right? So this can lower your neural tube defect risk. So for women who are planning to get pregnant, so the minimum dose is 400 micrograms of folic acid periconceptional until the first trimester. Pwede mo namang ituloy-tuloy all throughout your pregnancy. There's no harm in doing that. Pero ideally, you should have started it before conception, before organogenesis. But if you have a child with you have a prior child with neural tube defect, just like our case here, you have to increase the folic acid dose to 4 milligrams, okay? From 400 micrograms, magiging 4 milligrams. So sino pa yung iba na dapat nagpo-folic acid? Yung mga may seizure disorders, yung mga may epilepsy, whether or not nagtitake sila ng anti-epileptic drugs or meron silang recent epileptic seizure or matagal na, dapat ipagpo-folic acid mo sila because they are at risk for having your neural tube defects. Okay? I'm mentioning that kasi favorite topic yan sa board exam. Epilepsy, seizure disorders, and in pregnancy. Okay? So this will be my advice for her. So take folic acid 4 milligrams daily while she's trying to conceive her next baby. Now we'll go to the early pregnancy complications. So I will be presenting you with 3 cases. for your early pregnancy complications. Kasi tatlo lang yan usually, guys, pag may early pregnancy complication. What do you mean by early? Ang early is less than 20 weeks. So parang ultrasound din yan, guys. Diba sabi ko kanina, your early ultrasound is less than 20 weeks. Beyond 20 weeks, that's your late ultrasound na. Now we go to the first case. So you have a 21-year-old G2P11001. She came in with spotting. Pregnancy test turned out to be positive. So last normal menses was 12 weeks ago. So she's been amenorrheic for 12 weeks. And ang pertinent sa kanyang examination, cervix is closed. Corpus is enlarged to 10 to 12 weeks. So that is consistent with her amenorrhea. No adnexal mass or tenderness, and the ultrasound showed an embryo with no cardiac activity. So what is your diagnosis now? So dapat ma-diagnose nyo na to at your level. Okay, so as I mentioned a while ago, any patient in the reproductive age group presenting with vaginal bleeding, do a pregnancy test. So for this patient, it turned out to be positive. So less than 20 weeks yung patient, pregnancy test positive, ang iisipin mo agad is your early pregnancy complications. Itong tatlo lang yan usually. Abortion, ectopic pregnancy, or high datidiform mole. So paano mo sila ma-differentiate? Usually through your transvaginal ultrasound or your physical examination findings. So si ectopic pregnancy, obviously, ectopic meaning aberrant, wala siya sa tamang lugar, nasa labas siya ng matres. Yung makikita mo yung konsepto sa labas ng matres or evidence of pregnancy outside of your endometrial cavity. Your H-mole, mamaya papakitaan ko rin kayo ng picture ng H-mole, but you usually see a uterus filled with cystic spaces. So we call that a snowstorm appearance. Later on, I will show you an ultrasound of this. Okay, so for this patient, most likely, may ultrasound ka na eh. So in this, based on the ultrasound of this patient, sabi dito, ultrasound has an embryo with no cardiac activity. This is most consistent with your abortion. Okay, so this is a case of abortion, but what kind of abortion? So ito yung kinds of abortion natin, guys, and you can differentiate between one kind to another kind based on the following physical examination findings. So ganito ko siya nilist. This is intentional because this is like a spectrum. All right? So isa-isahin natin. So first of all, the first type is threatened abortion. When you say threatened abortion, nang ano lang yan, parang nang nananakot lang siya. Close yung cervix mo. Usually, they present to you with either uterine contraction or bleeding. So, close yung cervix mo, threatened lang, nananakot lang yan, buhay pa rin yung baby mo sa loob. So, the products of conception are still in utero. Therefore, your uterus is compatible with your LMP or with your ultrasound, whatever, or kung ano man yung ginagamit nyo na dating ng pregnancy. So that's your threatened. Buhay yung baby, closed ang cervix. Yun yung tandaan nyo. Therefore, dahil hindi naman lumalabas pa yung products of conception, compatible ang uterus. Next kind is your missed abortion. Technically, it's like your threatened abortion. They present very similarly, except you no longer have, either you have a non-viable pregnancy or nawala ng heartbeat yung baby mo. Alright? So, ang difference ni threatened at ni missed is the presence of a dead conceptus or a non-viable conceptus in your missed abortion. So, bakit ko sinasabi na incompatible or compatible yung uterus? Kasi when you say missed abortion, kaya siya missed, is, for example, you have a live conceptus. You have a live fetus at 9 weeks, for example, 9 weeks. And then, later on, at 12 weeks, magpe-present yung patient with bleeding. Alright? So, instead of 12 weeks yung corpus size mo, mapapansin mo na small lang siya. So, incompatible siya. Kasi nawala na siya ng heartbeat at 9 weeks. Kaya siya miss. Na-miss out mo yung time na nawala yung cardiac motion. So, when you did your missed abortion, you will use kung ano yung nasa ultrasound finding. So, kung halimbawa, nasa ultrasound mo is non-viable pregnant or an embryo consistent with 9 weeks AOG, hindi ka na magbe-base sa LMT. Okay? For the aging of this one. Remember, di ba? I told you na pag missed abortion, kung may ultrasound ka naman, we base the aging on the ultrasound rather than the LMT. That's why I noted it could be incompatible. The uterus could be incompatible to your LMT. Yung compatibility dito, guys, is based on your gestational age, alright? Pag compatible naman, anong ibig sabihin ko dito ng compatible? For example, what if na-catch mo siya around the same time that you lost your cardiac motion? Pwede siya maging compatible with your corpus size or your uterine size could be compatible with your gestational age. Alright? Naget? So, ang difference ni threatened at ni miss is si threatened live yung uterus. Live yung conceptus. Si miss, parehas silang close pero wala kang live fetus na pinoprotektahan. Alright? So, ang difference in terms of management, si threatened, we do tocolysis. Alright? We give them uterotonics. We give this patients progesterone, alright, para ma-keep yung pregnancy, to maintain the pregnancy. For your missed abortion, since closed yung cervix mo, we do cervical rightening. We try to open the cervix, and then later on, we either allow spontaneous passage of your product of conception, or we could perform curettage. Sa missed abortion, dito rin tayo nagda-dilatation and curettage. Kaya may dilatation and curettage, iba siya kay completion curettage kasi kailangan mo siyang, i-dilate mo pa siya. Kailangan mo siyang i-open kasi you have a closed cervix on internal examination. Naget? So, what if nag-open yung cervix mo? Okay? Open yung cervix, pero hindi naman lumabas yung products of conception. Kung conceptus mo nasa loob pa rin, nag-open lang talaga siya. What we do here is, what we label this is inevitable. So kaya siya compatible kasi nag-open lang yung matres mo. Nag-open lang yung cervix mo without expulsion of your conceptus. So pwedeng buhay, pwede yun guys ha, pwedeng may inevitable abortion ka, pero buhay, meron ka pa rin cardiac motion, cardiac activity, or pwede rin wala na yung you're dealing with a dead conceptus or a dead embryo. So for this, these are the management options. We can do expectant management. Kapag halimbawa you're dealing with a dead embryo, you may proceed with oxytocin drip para ma-expel na niya yung remaining products of conception. So remember guys, gagawin mo lang ng oxytocin drip kapag ganito ha, pag hindi siya live yung conceptus mo. And then you may proceed with curettage thereafter if there are still remaining products of conception despite your oxytocin drip. Okay, so kung si inevitable, nag-open siya pero walang passage of your products of conception, si incomplete, kaya siya incomplete because there is partial expulsion of your products of conception. Note that both inevitable and incomplete, they're open. So our mnemonic for this is both eyes are open. So ang inevitable abortion, incomplete abortion, you can distinguish them from other forms of abortion based on your cervical dilatation. By the way, when you report your IE findings for abortion, never report to us, Doktora, 2 cm dilated this abortion case. No, you don't mention that kasi hindi naman sila magiging fully dilated. So there is no need for you to mention how many centimeters open your cervix is. It's enough for us to say, or it's enough for you to describe the cervix as closed or open or dilated. Alright? So, wag kayong magre-report ng 5 cm. Wala kasing ganun. It's either closed or open. So, for your incomplete, ang difference na kay inevitable, may partial expulsion na siya. So, ang usual complaints ng patient nito, meron na pong lumabas na karne-karne. So, that karne-karne, that's your product of conception already, meaty material. So ito, dead conceptus na to guys, when you're dealing with incomplete abortion. So for this, our plan for this patient, usually we can allow them to pass out all of the products of conception. We could do that. But most of the time, we perform completion curettage. So that's different from your dilatation and curettage siya. Kasi open na to eh. Wala ka nang i-dilate. It's already open. So what you do, since incomplete siya, you do completion curettage. Alright? So your last kind of abortion is complete abortion. So the reason why it's already closed, hindi na siya open, is because na-expel na lahat. So, na-complete na niya yung pag-expel ng product of conception. So, the cervix is already closed. So, if your AOG based on LMP is 12 weeks, pero complete na siya, complete abortion na siya, then corpus should be reported as small already. Okay? Malit na yung corpus mo. So, there are no signs of pregnancy since na-expel mo lahat. So, for your complete abortion, usually, pinapauwi lang namin sila on say messaging para lang ma-completely, minsan kasi may content. Pag halimbawa may minimal meron na siyang minimal blood clot in utero, bibigyan lang namin yan ng messaging para malabas yung remaining blood clots. But if it's not that significant, we already label that as complete. Lalo na if close na yung cervix. This means na nakompleto na niya yung lahat ng ilalabas niya. Alright? So yung patient natin, ano siya? She is consistent with the case of missed abortion kasi wala na, di ba? Embryo with no cardiac activity and the cervix is closed. Alright? So she's a case of missed abortion early because 12 weeks, less than, 12 weeks and below siya. So important din sa amin yun, nililabel kung early or late. 12 weeks ang marker natin for early. Pag beyond 12 weeks and less than 20 weeks, that's your late abortion. So bakit siya important? So kasi kapag early, you can do completion curettage, no? So we have your curette for that. But beyond 12 weeks, you could already have bony spicules, okay? So we label that as evacuation, okay? Dilatation and evacuation. Pansinin niyo siya sa Williams. Hindi na siya dilatation and curettage beyond 12 weeks. Kasi nga may bony spicules na, mas malaki na yung conceptus. So, we label the procedure as dilatation and extraction or dilatation and evacuation. Ganyan. Hindi na siya curettage. Alright? So, yun yung isang importance ng labeling if the abortion is early or late. Okay? Sige. So, ito. This is what I mentioned. So another component or another aspect now we have to note in cases of abortion if it's non-septic. Because there are cases, guys, of septic abortion and you would usually observe them in cases of induced abortion. So yung mga naglimisoprostol, nag-instrumentation, ayan. So sila yung mga induced abortion. Yon. So itong si patients naman, hindi ko na-mention but I assume that this is the case of a non-induced abortion and wala namang mention of any septic signs such as fever or foul-smelling discharge. So ito yung full diagnosis niya. Missed abortion, early, 12 weeks. You mentioned how many weeks? Non-septic, non-induced. Okay? So this next patient, she came back actually after 2 days. Now she's complaining of vaginal bleeding with passage of blood clots and meaty material. So, minote ko to kanina. May meaty material tayo. Wait lang. Going back. Sorry. And then, if you notice, ulit, Mavi. Sorry, take two. Okay. So, let's move on. So, this patient, she actually came back after 2 days. She's now complaining of profuse vaginal bleeding with passage of blood clots and meaty material. So alam niyo na kung anong meron dito. And on bimanual examination, her cervix was open. Corpus was small with no adnexal mass or tenderness. What is your new diagnosis? So 2 days ago, missed abortion siya. Siya lang ay probably you sent this patient home on cervical ripening agents like your Ivprim or any other preferred cervical ripening agent of choice. So after 2 days, nag-ripen nga yung cervix niya. Now she's presenting with passage of meaty material, and profuse bleeding, and open na yung cervix niya. So, dalawa lang yan pwede, di ba guys? It's either incomplete or inevitable abortion because all eyes are open. So now she's a case of incomplete abortion. There is partial expulsion already of your product of conception. So how will you manage the patient now that you know that she's a case of incomplete abortion? So you will perform completion curettage. Kaya completion kasi kino-complete mo ang incomplete abortion. So you're trying to remove all the products of conception that are still retained within your uterus. All right? Okay, next case. Case number 2, for your early pregnancy complications. Andun pa rin tayo. So this is less than 20 weeks. We have a 32-year-old G3T22002. So may clue ka na dito. This patient is currently pregnant. She consulted at your clinic with 1-week history of spotting with no associated abdominal pain. And she claims that she is 2 months pregnant. So she's probably amenorrheic already for the past 2 months. Her ultrasound results showed no evidence of intrauterine pregnancy with a 6-centimeter complex mass adjacent to the right ovary. Okay, so this is a suggestive finding. Suggestive lang to. No intrauterine pregnancy, pero meron kang complex mass sa adnexal area. Ito ang clincher. Within the mass is a gestational sac with a single live embryo, which is the most appropriate management. So since clerks na kayo and interns na kayo, aside from diagnosing, we could also ask you regarding your opinion sa management ng mga patients ninyo. So first, so I noted these three symptoms, no? Vaginal bleeding, abdominal pain, and amenorrhea. So let's just assume itong 2 months pregnant na kiniklaim niya. This is because she's been amenorrheic for the past 2 months. So amenorrhea, spotting, abdominal pain, this triad composes your triad that will make you think of ectopic pregnancy. So to consider ectopic pregnancy pa lang tayo. And note itong patient, wala siyang abdominal pain, but that's okay. That also happens in cases of ectopic pregnancy. Lalo na if in cases of unruptured ectopic pregnancy. Okay, so paano tayo sure na ectopic pregnancy na to? Because she has no evidence of intrauterine pregnancy. But as I told you, yung no intrauterine pregnancy na may complex adnexal mass adjacent to the right ovary, that's only suggestive. Ang talagang true definition niya is when you see the gestational sac in a place that is aberrant or that is ectopic, meaning outside ng uterine, within the uterine cavity. Okay? So kapag ganon, you know that pag nakita mo to on ultrasound, you know that you're dealing with ectopic pregnancy. Ito swerte ka na nakakita ka ng gestational sac or GS outside of the mattress, outside of the endometrial cavity. Pero what if wala? Meron ka lang complex mass and then symptoms of ectopic pregnancy. So you put to consider ectopic pregnancy. All right? So your ectopic pregnancy, as I mentioned, is pregnancy that happens outside of where your fertilized egg should be implanted, which is inside your endometrium. So the most common site is your tubal location. So kapag halimbawa na operahan mo na itong pasyente, no, nakita mo na sa fallopian tube na siya, you change your diagnosis. It's no longer ectopic pregnancy. You change it to tubal pregnancy. Now, in tubal pregnancy, ang pinaka-common is your ampullary region. Diyan yung pinaka-common site ng ectopic pregnancy. Bukod sa siya yung widest part, this is also the part where fertilization occurs, okay, in your ampullary region. Kaya dyan din mostly nangyayari yung ectopic pregnancy. So, ano ang nagpe-predispose sa'yo sa ectopic pregnancy? As you can see, dahil tubal yung most likely location ng ectopic pregnancies nyo, anything that alters the motility of your cilia inside your fallopian tube, anything that alters your anatomy, your tubal anatomy, that will predispose you to ectopic pregnancy. So anong example nun? If you have pelvic inflammatory disease or yung mga STDs but in the upper genital tract. So that will cause that will cause adhesions in the tubal structure or pwedeng sa outside ng tube or pwede rin nagkakaroon sila ng hydrosalpinges. Pwede kang magkaroon ng ectopic pregnancy. If you have a prior tubal surgery, that will also predispose you. If you have pelvic endometriosis because of the pelvic adhesions, presence of inflammation, that will cause you to have, that will predispose you to having ectopic pregnancy. Okay, so sabihin na natin na most of the time sa ampullary region, dito tayo nakakakita ng ectopic pregnancy. Pero saan kami pinakatakot, guys? Saang location within the tube, the fallopian tube that we are most worried, ito sana yung hindi matapat sa amin pag kami yung duty. So ang pinakatakot kami is this one, this location, the interstitial. So interstitial, this is still part of your tubal anatomy, no? So your fallopian tube. Pero as you can see, it is so close to your myometrium already, to your uterus. So bakit kami takot sa interstitial pregnancy? Okay, because of two reasons. First is, kapag nag-rupture ang interstitial pregnancy, it will cause catastrophic bleeding. Why catastrophic bleeding? Because you have supply coming from your uterines. Okay, so pag ito nagkaroon kami ng interstitial pregnancy at nag-rupture yon, hindi lang 1 liter ang hemoperitoneum namin ito usually. Usually sobrang mas madami pa. Okay? So meron din siyang supply from your ovary, from your ovarian artery. Okay, so dahil sa kanyang rich vasculature, you could have catastrophic bleeding. So aside from that, ang interstitial pregnancy, it can go further. Yung gestation niya mas malaki. Mas nag-rupture siya later, yung gestational age. Why? Because of the distensibility of your surrounding myometrium. So bakit kami takot doon? So ibig sabihin, mas malaki yung conceptus mo, mas well-developed yung vasculature niya, mas madugo. Okay? So pag ganon, we do wedge resection, cornual wedge resection with salpingectomy. We no longer save the fallopian tube kasi hindi rin naman namin siya ma-re-implant, okay, into the uterus. Since tinanggal na namin yung plant where it's supposed to be implanted. Alright? So ito yung ayaw namin, the interstitial pregnancy. This is not cornual pregnancy, okay guys? Kasi ang cornual pregnancy, that is designated for a Mullerian anatomy, yung sa cornu. Okay, so dito cornu, interstitial part siya of your fallopian tube. So it's a misnomer if you call an interstitial pregnancy a cornual pregnancy. But that is, a very common misnomer among obstetrician gynecologists. Alright, so how do you manage this patient? So let's focus on the tubal lang muna. So there are 3 ways by which you could manage these patients. First is medical, using methotrexate. So dahil student namin kayo, dapat alam nyo yung exact mechanism of action ng methotrexate. Okay, so second option is surgical. Third, we can do expectant management. There is also room for expectant management in ectopic pregnancy. So tuwing kailan natin gagamitin tong mga to? Okay, so let's focus muna sa medical management. So the mechanism of action of your methotrexate is that it's a folic acid antagonist. So to be exact, later I will show you, it inhibits your dihydrofolate reductase. So sino-sino yung mga pwede mong i-medical management? So patients who are asymptomatic, compliant, and hemodynamically stable with low initial beta HCG of less than 5,000. Okay? Kasi kapag mas mababa, mas likely kami na pag mas mababa, mas mataas yung chance mag-work si methotrexate. Alright? So less than 5,000. Second, dapat small yung ectopic pregnancy size. I think I highlighted this one because the case that I provided you ay 6 centimeters in size. So dapat less than 3.5 centimeters. And there should be no fetal cardiac activity. Remember, if we go back to the case, single live embryo. sa adnexal area, adjacent to the right ovary, tapos empty yung matres. So, okay, so hindi automatic, hindi na tayo magme-methotrexate because we have a contraindication for your methotrexate treatment. So as I mentioned, your methotrexate inhibits your dihydrofolate reductase. So dihydrofolate reductase prevents the reduction of your dihydrofolate to tetrahydrofolate. So this, yung cascade na nagpo-produce nito will give you purine synthesis. So ang overall na ginagawa ng methotrexate is that it arrests your DNA, RNA, and protein synthesis. Okay? Na-get? So tandaan niyo si methotrexate ha, pati yung mechanism of action niya, kasi hindi lang siya important sa ectopic pregnancy, important din siya for the next early pregnancy complication, which is your molar pregnancy. Alright, so since nga it arrests your DNA, RNA, protein synthesis, it is therefore highly effective against your rapidly proliferating tissues such as your trophoblast. So bukod sa trophoblast, ang mga rapidly proliferating are the following: bone marrow mo, GI mucosa, respiratory epithelium, hepatocytes, and renally excreted siya. So that's why you have to check your CREA before you give your methotrexate. So given this effect of methotrexate, ma-deduce mo na kung ano yung mga common side effects niya. So ang usual sa mga patients na may mild methotrexate side effects, ang kino-complain nila, meron silang singaw, stomatitis, gastritis, ganyan. Kasi it's also active against other rapidly proliferating tissues other than your trophoblast. And to be fair, with methotrexate, it approximates 90% resolution with use, okay? So, ito, kayo na bahala mag-memorize nito in your own time. There is just one thing that I would like to emphasize here between ito, sa single dose. Kasi usually sa single dose kami eh. So, ang tinitingnan namin dito, guys, is days 4 to 7. Okay? Days 4 to 7, yung tinitingnan namin. So, pag di ba, meron kang baseline, beta HCG. So, pag halimbawa, hindi less than 15% yung decrease niya between day 1 to day 4, okay lang, don't panic. That's not what we look at. What we look at is yung between day 4 to 7. Alright? Kasi pag hindi, pwede kami magbigay ng another dose ng methotrexate. Okay. So, saka ito yung marker namin ng success, yung between day 4 to 7. Yan. Okay, so next option for management is your surgical management. So, sino yung surgical management namin? Yung mga hindi nagko-qualify for medical management. So, what are your options? So, ideally, laparoscopy talaga or your minimally invasive surgery. That's what we prefer for our patients with ectopic pregnancy versus laparotomy, which is open, no? Parang cesarean section scar. Midline, pwede rin transverse. Minsan yung nagta-transverse na skin incision. So, ang gusto talaga natin is laparoscopy, minimally invasive, unless the patient is hemodynamically stable. So, kapag ganon, mas mabilis na laparotomy or open. Open yung approach sa surgery. So, these are your options for your for your surgical management: salpingostomy, salpingotomy, salpingectomy. Madali lang to. Si salpingectomy, tanggal lahat. For salpingostomy, this is our first option for your surgical management. We place a linear incision along the anti-mesenteric border. So, ano ba yung anti-mesenteric border, Doctor? I cannot understand. The anti-mesenteric border dito sa side na to, instead of here. Okay? Right. Yan. So, kapag hindi naman ganun ka ruptured, wala kasi talagang strict na criterion na for salpingostomy versus salpingectomy. But basically, for salpingostomy, kapag kaya mo pa rin i-retain yung anatomy just by doing the incision and flushing out the product of conception, this is what we prefer to do instead of completely removing your fallopian tube. Pero pag halimbawa super ruptured na, hindi na maganda yung wala ka ng choice but to remove the entire fallopian tube, ito, salpingectomy yung ginagawa or total removal of your pathologic fallopian tube. So salpingostomy, linear incision lang, and then you flush out the products of conception, usually with sterile water, and then the incision will not be sutured. Ang difference niya, tingnan sila ni salpingotomy, except si salpingotomy, isusuture mo siya. So baliktad, no? Kung sino yung may S, yun yung walang S, suture. Pero yung walang S, yun yung isusuture mo. Okay? Basta ganon. Yun yung ano natin. Ganon ko siya naalala before. Alright? So expectant. I'm sure hindi kayo masyadong familiar with this, but actually we can do expectant management for cases of ectopic pregnancy. Pag maliit yung ectopic pregnancy, like less than 3 centimeters, and the beta-HCG levels are less than 1,500. Alright? So, X na agad dito si patient, di ba? Kasi si methotrexate, kasi live yung embryo niya, so we can't give methotrexate. X na rin siya sa expectant kasi 6 centimeters yung mas malaki siya para lang mag-await ka lang dyan. Alright, so for our plan for this patient is surgical management. So dito, ang surgical management is, ito lang, si letter D, perform salpingectomy. Alright? Okay, we go now to the third and last case for early pregnancy complications. We have a 41-year-old G7 P6 6006. So this is a grand multipara. Note, di ba? P5 and above, P6 siya. Okay, she came in for prenatal consult. So she knows that she's pregnant. She's been amenorrheic for the past 12 weeks. PT or pregnancy test is faintly positive. Dapat magtaka ka dyan, ba't ka faintly positive? Hindi ba dapat ang peak mo ng beta-HCG 10 to 12 weeks? Bakit ka faintly positive? So anyway, okay, it's true that she's pregnant. She has a positive pregnancy test. So pertinent on her PE, her heart rate, she's tachycardic, 120s, closed ang cervix niya, no bleeding, and her corpus is enlarged to 20 weeks. Remember, meron tayo, di ba? Na-note kanina, if your fundus height or your corpus size is greater than your LMT or your computed gestational age, isa to sa mga iisipin mo. Okay? So obviously, yung isa na lang na hindi ko na mention or hindi ko na discuss sa early pregnancy complications, it's molar pregnancy or H-mole or kiyawa. Alright. Sige, doon tayo sa pregnancy test. Bakit siya faintly positive, doktora? Or sometimes nagpo-false negative sila. What is the reason behind that? Okay, I'll try to explain it to you. So kapag meron ka kasing highlighted before mole or molar pregnancy, meron kang superabundance of your trophoblast. So when you have superabundance of your trophoblast, you have increased beta-HCG. Sobrang dami mong beta-HCG. Okay? So kapag marami kang beta-HCG, ang normal pregnancy test ganito. Dapat, ito yung, I don't know how to call it, pero antibodies, let's say they're the antibodies in your test kit, dapat isa-sandwich nila yung beta-HCG. Dapat ganito yung magiging itsura nila. So, nagpa-positive ang pregnancy test mo if meron kang enough amounts of your beta-HCG na nasa sandwich between two antibodies. Na-get? Okay, so yan ang mag-produce ng red line mo pag normal pregnancy. However, in cases of H-mole, ito yung beta-HCG mo, instead na mag-sandwich between two antibodies, yung beta-HCG mo, ang nangyayari, sa sobrang dami, nag-prepare yung beta-HCG with the floating antibodies. Dalawang set kasi yan ng antibodies, guys. Isang fixed lang, tapos isang free-flowing, okay? So, dapat magsa-sandwich siya. Ito yung magre-red line. Ito yung magpa-positive pregnancy test. So ito, hindi sila maka-form ng sandwich because sa sobrang dami, pati yung mga free-floating na antibodies ay kinakabitan ng beta-HCG. So this is what happened. Okay? So for this reason, what we do is we dilute the serum beta-HCG. Pag negative yung patient on pregnancy test sa usual urine pregnancy test kit, it's and we have a high index of suspicion, like in this case, ang ginagawa namin, we order dilute serum beta HCG. Okay, so take note of this. Kapag meron kang H-mole patient, gestational trophoblastic neoplasia patient na ang expectation mo by the 100,000s, by the millions even, yung beta HCG, dilute yung i-order mo. Okay? Because otherwise, it will produce this effect. Okay? Which will cause false negative. Kasi walang nagsasandwich eh. So, paano magpa-positive to? So, another way, kung halimbawa, wala naman kayong serum beta HCG in your province or in your local setting, you can do 7-dilutional urine pregnancy test. So, basically, yung wee-wee, ita-transfer mo siya. Like, for example, if you have 10, ano lang to ha, parang wala, hindi siya by the book. But for example, you have your urine sample, you transfer it to a vial of sterile water. You transfer siguro mga 1 ml of that. And then after that, you transfer another 1 ml to another 10 ml vial. Ganyan, so on and so forth. So technically, what you're trying to produce is kung ano yung social na dilutional serum beta HCG na ginagawa. No? So ang point mo lang is ma-dilute yung beta HCG enough para ma-form tong sandwiching na to. Alright? May isa pa tayong tawag dito. We call this the hook effect. So bakit siya hook effect? Kasi kung ipa-plot mo yung concentration ng beta HCG against its absorbance on any test kit, whether urine or yung pang serum, para siyang hook, shape of a hook. Itong area lang na to, ito yung bound. Ito lang yung bound na antigen. Ito lang yung bound na beta HCG. So, ito lang yung certain amount na magpo-produce ng positive effect. The rest ay parang isa-saturate na niya yung available antibodies mo in your test kit. So, hindi mo siya makikita na magpa-positive. So, ito yung false positive. So, if you plot that, at makikita niyo naman, kitang-kita mo siyang hook, di ba? So, kaya siya hook effect. Alright. So, broccoli. Broccoli, para siyang grapes, no? Bunch of grapes yung description sa kanya. In Filipino and how the patients would describe it, may lumabas po sa akin parang sago-sago. Okay? That's how they would describe it. If you look at it on ultrasound, para siyang snowstorm appearance, no? So you will see may cystic appearing mass within the endometrial cavity. So that represents itong mga anechoic, di ba? Anechoic is mga black. So mga anechoic spaces dito, nire-represent inside yung laman ng grapes, di ba? So walang echoes na bumabalik. So kaya siya anechoic. So itong mga grapes na to, this is how they manifest on ultrasound. So ito naman yung kanilang histology. The villi are hydropic. Okay? So ito, happy na kami kung halimbawa ma-recognize nito on ultrasound. So on ultrasound ba, ma-distinguish mo kung partial or complete mole? Kasi we have two kinds of molar pregnancy. Technically, no? Dapat histopathology yan. Minsan nga nagpapa-immunostain pa kami for that. But pag halimbawa, meron kang twins, tapos meron ka ding hydatidiform mole in the same ultrasound within the same uterus, yun, sure ka na partial mole because that will not happen in cases of complete mole. Alright? Sige, so let me go to the differences between complete versus partial H mole. In your handout, mas mahaba pa to, pero ito yung mga gusto kong i-emphasize. First of all, iba yung pathogenesis nila. So sa complete hydatidiform mole, complete molar pregnancy, ang nangyayari is you have an empty ovum that is fertilized by one sperm. Okay? So remember, di ba, 23X. So 23 yung laman ng chromosomes ng sperm at ng egg. So supposedly, meron ding 23 something dito, di ba? 23 chromosomes sa ovum mo. However, what happens in your cases of complete mole, empty yung ovum, so ang nagduduplicate is your paternal chromosome. Kaya siya diandric, okay? Ang ibig lang sabihin ng diandric, nagko-contribute twice ng chromosomes yung andric, yung tatay, yung male counterpart ng gamit mo. Pero ito, technically, hindi siya nag-contribute ng dalawang 23X. It just so happened na nag-duplicate siya while fertilizing an empty ovum. Alright? So, kapag siya ay kinaryotype mo, 46X siya. Yan. So, ang incomplete or your partial mole, what you see is that your ovum is being fertilized by 2 sperm. So, ito yung marami, no? Dispermy siya. So, ang lumalabas, triploid. Alright? Triploid yung karyotyping mo. So, you have both maternal and paternal chromosomes. So this is not compatible with life. But in your partial mole, ito yung pwedeng magkaroon siya ng twins na viable pregnancy. That happens, and that is rare, but that happens. So ano yung mas gusto mo? Complete or partial? So between the two, what we don't like is your complete mole. Why? Because your complete mole has a higher chance of subsequent GTN. GTN stands for gestational trophoblastic neoplasia, which is the malignant counterpart of your gestational trophoblastic disease. So yung molar pregnancy, your gestational trophoblastic neoplasia, lahat yan under ng GTD or gestational trophoblastic disease. So yung GTN, that is the malignant counterpart of your the malignant types in your GTD, under GTD. So 15 to 25% yung chance mo of subsequent malignancy following a complete mole, while 0.4 to 5% in partial or incomplete moles. Alright? So, syempre, mas gusto natin yung lesser chance na mag-cancer, which is your partial mole. So, saan ko nakuha tong values na to? Guys, sa CPG. So, by your local CPG, your trophoblastic disease CPG. So, pag nag-repeat kayo sa PGH, it's available in our office. And, okay, so another one that I would like to highlight, so sometimes grossly, hindi mo naman din ma-distinguish yung complete versus partial mole. And sometimes, nahihirapan din yung mga pathologists, even on histology. So, in those times, we can order immunostaining. So, your partial mole, they are positive for your P57 KIP2 immunostaining. So, alalahanin nyo na lang to, guys. So, itong immunostain na to, this is positive in H mole because this is maternally expressed. Okay? So, remember, between the two, sino ba yung may empty ovum? Si complete. Si incomplete or si partial, meron siyang ovum. Okay? So, may maternal chromosomes na nakakontribute. So, siya lang yung magpa-positive for this one. That is maternally expressed. Okay? Nasa maternal allele to makikita. Si P57, KIP2. Yan. Yun na lang yung tandaan ninyo. Okay? So, between the two, sino sa tingin nyo yung mas mataas yung beta HCG? Siyempre, yung mas mataas yung risk for cancer, which is your complete mole. So, mas hindi talaga natin gusto si complete versus partial mole. Alright, so ano yung mga labs na i-order mo? So, first, you order your CBC because one medical complication of your molar pregnancy is anemia. Also, kasi may procedure ka dito mag-surgical procedure ka definitely for cases of molar pregnancy. Second, your liver function test, especially if you're considering giving your methotrexate for chemoprophylaxis. A renal function test. So this is important because your methotrexate is renally excreted. Thyroid function test. Bakit to important, guys? Remember, itong particularly for this patient, meron siyang hyperthyroid symptoms, no? Nagpapalpit, hindi ko sinabing nagpapalpitate siya. Pero she's tachycardic. She has 120s, I believe, na heart rate based on my clinical scenario. And also, bakit tumataas ang thyroid function test or your FT4? FT4, ito yung tumataas, no? FT4, FT3. Bakit siya tumataas? This is because, remember, your alpha subunit of your beta of your HCG is similar to that of your TSH. So, nasa-stimulate din niya yung thyroid hormones. Okay? So, pwede kang mag-thyroid storm. Hindi siya rare for us to see H-mole patients na nagka-thyroid storm. So, we're very wary of this complication in our patient. So, next, urinalysis. So, itong patients natin, bukod sa, syempre, you have to check for infection, given na yan, especially mag-give ka ng methotrexate. One more thing, patients with superabundance of trophoblast, they are predisposed to having preeclampsia. Okay? Ito lang yung case ng preeclampsia na pwede mong i-diagnose before 20 weeks. Kasi alam mo na it's because of your placenta, there is superabundance of trophoblast. So, okay lang po ba, Doctor? Baka naman pag meron kayong molar pregnancy, tapos, di ba, 16 weeks, kunwari, yung molar pregnancy mo. Tapos, 160, 110, Doktora, chronic hypertension yan kasi less than 20 weeks. No, guys, preeclampsia siya kapag in the presence of molar pregnancy. Because you know na increase ang kanyang hormonal placental hormones secondary to the superabundance of your trophoblast. Na-get? So, sa urinalysis, titingnan mo yan si dipstick. Kung magpa-positive or mag-negative, you check for presence of proteinuria. So, chest X-ray, pre-evacuation, you have to have a baseline. Alright? Kailangan may baseline ka. Kasi in the future, pag nag-GTN tong patient na to, you check the baseline chest X-ray of your patient. Okay? Pwede rin sila, ito, ang pangit din sa H-mole, pwede silang mag-throw ng trophoblast. And sometimes, there are cases na nag-throw sila up to the pulmonary vessels. Okay? So, na ganun, nagpupulmo-embos sila. So, isa to sa mga watch out for namin at kinatatakutan namin in cases of molar pregnancy. So, actually, nakakatakot talaga magkaroon ng piyawa patient, no? Very toxic sila. They could have any medical complication na kailangan mong i-address prior pa to your surgical evacuation. And of course, you have to have serum beta HCG na diluted. So this is marker mo siya if you have successfully evacuated sa molar pregnancy. So ito yung titingnan mo, si serum beta HCG. So pag ito tumaas or nagplateau, yung pagbaba niya, matakot ka na kasi baka nagkaroon ka na ng malignant transformation to gestational trophoblastic neoplasia. We don't like that. Okay? Alright. So the plan is always surgical. Alright? Hindi siya medical ever. Okay? For H-mole. Yung medical management lang, yung nakikita yung kinikimo lang namin, hindi kailangan ng surgery. GTN yun, guys. Okay? Hindi yun buntis na patient. They're considered GYN patients. They're considered cancer patients. Ito ay buntis na patients whose products of conception you have to evacuate. So, how do you evacuate? Ang first line natin na ginagawa is suction curettage. Alright? So, instead na curette, if you see parang ang curette is para siyang mabiyang tawag din, para sa buko.
Sorry, yung alin?
Buko. Ang curette, ano yung itsura ng curette? Parang buko. Ang kayod ng buko. Anyway, yun na lang sabihin ko. Okay, action. So, di ba yung sa completion curettage, we use ovum saka sharp curette. So, yung sharp curette, ang naisip ko na very similar sa kanya tingnan is parang yung pangkayod ng buko. Yeah, okay. So, yun yung parang, if you can imagine it, parang ganun siya, di ba? Si suction curettage, as in suction talaga siya because you're trying to suction the hydropic villi, okay? The bunches of grapes, the sago-sago, yun yung kailangan mong i-evacuate. So, ito yung first line. Lalo na if nag-bleed na yung patient or hindi siya surgically ready for very major operation, we do suction curettage. This is what we do first line. However, for this patient, if she has completed family size, if stable naman yung patient, you have available blood, the patient is amenable, you can perform actually hysterectomy with or without bilateral salpingectomy. Okay, it depends on you, with mole in situ. Anong ibig sabihin ng mole in situ? Tatanggalin mo yung matres ng nasa loob yung products of conception, ng nasa loob yung H-mole, okay? Your molar pregnancy, the bunch of grapes, ayan. Tatanggalin mo siya. Habang hindi mo siya kailangan i-suction din, then i-hysterectomy mo. Is an i-hysterectomy mo, tatanggalin mo the matres with the molar pregnancy inside. So we reserve this for patients who are relatively old who have already completed family size. So ito 41 G7 na to, di ba? Tapos, ang maganda dito sa PH with mole in situ, this decreases the risk for local invasion. Not to say na hindi sila mag-GTN, pwede pa rin naman. Di ba? Pwede pa rin mag-throw yan sa anywhere within your pelvic cavity and mag-present siya with increasing beta HCG. Pwede pa rin yun. Pero, syempre, markedly decrease na yung risk mo for local invasion or risk of transforming to GTN. Kasi tinanggal mo na yung matres, tinanggal mo na yung myometrium where your molar pregnancy or your trophoblast could invade. Alright? So, si patient, pwede mo siyang i-offeran nito. So, stable naman siya. She's not bleeding. She's already 41. She's G7. And based on her overall picture, mataas yung risk niya na malignant transformation to GTN. So, I would offer hysterectomy for this patient, no? If she's amenable and if all other surgical considerations are okay and ready. Okay, so say pagbukas mo guys, pagbukas nyo, ganito yung nakita nyo sa ovaries. The ovaries look like this, parang atis, okay? So, cyst din siya, parang cystic na bilateral. So, usually bilateral yan, cystic looking, tapos malalaki. Sabihin natin tong size nito ay, it's almost the size of your uterus. So, sabihin natin 8 centimeters bilaterally. Anong gagawin mo dito sa cyst? Do you do oophorectomy? Do you do cystectomy? Do you aspirate this? What do you do? So these are thecal-lutein cysts. So ito is as a reaction din to ng ovaries to your increased beta HCG. So ang nangyayari naman dito guys, this resolves spontaneously kapag na-remove mo na yung molar pregnancy. So your thecal-lutein cysts, hindi mo sila ginagalaw, okay? Don't do oophorectomy or cystectomy, whatever, leave them be, all right? They would regress usually 6 weeks postpartum if wala naman ng stimulation ng beta HCG in the patient. Alright? So, yan, yung thecal-lutein cyst. So, sa age mo lang ba to? Pathognomonic ba to, doktora? Or is this only seen sa molar pregnancy? No. Pwede din siya in any case na may increased beta HCG such as your multifetal gestation, pwede din. But more commonly sa H-mole namin to nakikita. So ganito siya on ultrasound. So anechoic, cystic spaces na multiloculated and usually bilateral. Rarely mo yan sila makikita na unilateral. Usually bilateral ang thecal-lutein cyst because both are hormonally responsive organs, your left and your right. Alright? So, di mo siya gagalawin. So, okay, going back to this patient, molar pregnancy siya. Okay, this is just to review yung overall picture ng patient. Take note of the age. Take note of the, the heart rate. Sabihin na natin may thyrotoxicosis to. Hindi ko lang na-note sa, sa kanyang symptoms. And note the corpus size. 20 weeks versus an amenorrhea of 12 weeks. So why am I asking you to note those things? Because these are criteria for her to be given chemoprophylaxis. Chemoprophylaxis, anong chemoprophylaxis? Prophylaxis saan, doktora? Para hindi sila mag-GTN. And we give this first line in the form of methotrexate. So first risk factor ni patient, more than 40 years old. Okay, the uterine size is larger than gestation by 6 weeks. So may 8 weeks difference, diba? 20 weeks versus 12 weeks size. Thecal-lutein cyst, diba? I mentioned kanina, 8 centimeters yung tigisang thecal-lutein cyst. So, inassume ko na lang may thyrotoxicosis. So, kunwari lang, okay. Anyway, even with just one of these criteria, magbibigay ka ng methotrexate, okay? So, ayan. So, yung mga sinasabi ko sa inyong mga medical complications. So, very complicated. This is a very complicated and case that we really watch out for. Alright. So, sabihin natin na hindi na hysterectomy si patient. Diba? Na-suction curettage lang siya. Ano yung magiging advice mo sa kanya for her next pregnancy, for her G8? Alright? So, first of all, post-suction curettage, you advise her to take low dose OCT for contraception. Bakit? Because she is not allowed to get pregnant in the next 6 months. So dapat 6 months after normal beta-HCG. So after mo kasi mag-suction curettage, you will do surveillance, no? You will keep testing her beta-HCG. So once maging normal siya, may 6 months leeway ka na dapat hindi ka magiging pregnant. Okay? So kaya ka nag-low dose OCT. Otherwise, kapag nabuntis ka, makukonfuse ka. Pwedeng ma-label yung patient na GTN, yung pala, buntis lang pala siya. So yung increasing beta-HCG niya is not because of an invasive mole or anything like that, but because of a pregnancy. So you have to be strict with the contraception of these patients. Now, sakaling mabuntis siya, nag-G8 pa rin siya kasi hindi mo siya hysterectomy. Okay, what you do is do an early ultrasound, okay, as much as possible at less than 12 weeks to rule out molar pregnancy because this condition recurs. Second, you have to perform serum beta-HCG 6 weeks postpartum. Why? To rule out occult GTM, okay? To rule out occult GTD, or gestational trophoblastic disease, occult molar pregnancy. And last, you have to submit the placenta for histopathologic exam for the same reason. You have to rule out occult gestational trophoblastic disease for her next pregnancies. So, ang daming consideration. So, sabihan mo na lang, wag na munang magbuntis, or if they're really, really desirous, wait 6 months until mag-normalize yung beta-HCG. Okay, now we're done with the early pregnancy complications. So now, we'll look at the patient naman beyond 20 weeks, diba? So yung early pregnancy complications, that's less than 20 weeks. We're done with abortion, hydatidiform mole, and ectopic pregnancy. So now, dun naman tayo sa mga second to third trimester patients. So I'll be giving you an index case. Our patient will be OB. Okay, she's a 35-year-old pre-gravid. Based on her amenorrhea or her LMP, she's 30 weeks AOG. But based on her early ultrasound done at 10 weeks, so this is an early trimester ultrasound, first trimester ultrasound, she's 30 weeks and 2 days. So, alin yung i-follow natin, guys? The amenorrhea or the early ultrasound? So, for her case, we'll be using the amenorrhea since compatible naman yung amenorrhea niya with the early ultrasound. Okay? Tingnan yung difference is only 2 days. So, pwede natin gamitin yung amenorrhea for the aging. Okay? So, tingnan natin kung ano yung mga napagawa ng patient natin na imaging. So, very compliant tong patient natin na to. At 10 weeks, as I mentioned, meron siyang transvaginal ultrasound. So, again, why transvaginal yung route ng ultrasound niya? This is because less than 12 weeks, less than or equal to 12 weeks, pelvic organ pa yung uterus. So, that's why transvaginal yung route ng ultrasound niya. Okay, so at 20 weeks, sobrang compliantly patient, meron ulit siyang ultrasound. So, a biometry was done. So, sa biometry, marami ng diameters yung minimeasure dito. That includes your biparietal diameter, the head circumference of the baby, the abdominal circumference, ayun. Okay, so yun yung mga diameters na minimeasure mo sa biometry because your fetus is big enough to be measured. So for this patient, a congenital anomaly scan was done at 20 weeks. So kailan ginagawa yung congenital anomaly scan? At 18 to 20 weeks. Bakit ginawa yung congenital anomaly scan for the patient? So technically, di ba, pwede mo siyang i-offer to all patients. But particularly for this patient, we are doing a CAS or a congenital anomaly scan because look at her age. She's 35 years old. Okay? So, at 26 weeks, she was diagnosed to have gestational diabetes mellitus. So, review lang natin dun sa na-discuss ko na previously. At 24 to 28 weeks, diba, nagpapa 75 gram OGTT tayo. So, okay, it just so happened, meron siyang GDM. So, this time, nagpagawa ulit tayo ng another diagnostic. So, this time, we had a biometry with Doppler studies done. So, para saan yung Doppler studies? Yung Doppler studies is to see if the patient has uteroplacental insufficiency. Diba? So in cases of GBM, preeclampsia, APAS, or any other comorbid conditions ng mother that will predispose her to having uteroplacental insufficiency, that's when we order your Doppler studies. Okay? So ito yung mga napagawa ni patient. So very good, very compliant patient ito. Okay. So now, this patient, for her case, your resident in charge ordered the following. So 30 weeks na siya. So nag-order siya ng biometry with BPP. Okay? So may bago na naman tayong matututunan ngayon. So what is BPP? Your BPP, sometimes called also your BPS, it stands for biophysical profile. Okay? Or biophysical score. Ano ba tong BPP? Okay. So your BPP, essentially, it's a test for fetal well-being. Tinitingnan mo, parang ito yung vital signs essentially ng baby mo. So ano yung mga components ng biophysical profile? So these are your components. Kailangan ba itong i-memorize? Personally, oo. I think kailangan yung i-memorize to if you will be rotating in OB. So there are 5 components. Your NST, your fetal breathing, fetal movement, fetal tone, and your amniotic fluid volume. So itong first 4, according to our ultrasound textbook, which is Callen's, itong 4 na to, these are acute components. Meaning kung may acute injury, ito yung mga na-affect. Okay? Ang chronic component is your amniotic fluid. So kung mas matagal na yung injury, ang na-affect niya is yung amniotic fluid. Okay. So, anong mnemonic mo, doktora? Kasi medyo bago sa amin to, paano namin maaalala yung BPP. So, BPP sounds like Batman, okay? Batman. Okay. So, bakit BPP man yung mnemonic ko? So, this is Batman. B stands for breathing. A stands for amniotic fluid volume. T stands for tone. M is for movement. N is for NST. Okay? So yung 1, 2, 3, mamaya explain ko yan, isa-isa. So dito muna tayo kay breathing. Yan. So sa biophysical profile, guys, you either get a score of 0 or 2. Okay? So magtaka ka kapag meron kang BPP score na ang report sa'yo ay odd number. That never happens. Okay? It's puro even numbers or 0. Yan yung mga natin. Yan lang yung pwede mong maging BPP score. Alright, so isa-isahin natin. So for breathing, you have to have at least 1 episode of rhythmic breathing lasting at least 30 seconds within 30 minutes. Kaya siya 1. Ilagay ko dito 1. So si amniotic fluid volume naman, 2 yung dinenote ko dito because ang kanyang component score na 2, there should be an amniotic fluid pocket na greater than or equal to 2 centimeters. Dapat, guys, 2 planes perpendicular to each other. So, essentially, basta maganda yung normohydramnios ka, may normohydramnios, mamaya i-explain ko yan kung ano yung normohydramnios, you give a score of 2 for your patient. Alright? So, for your tone ay at least 1 episode of extremity extension and subsequent return to flexion. So, nag-extend ka dapat, tapos may flexion. Sometimes, ang tinitingnan ng mga sonologists is the hand opening and closing. Okay? So, that's considered tone. Next is movement. Next component, movement. So, there should be at least 3 discrete body or limb movements within 30 minutes. So essentially, you have to watch your patient for the next 30 minutes. Yun ang full BPP scoring. Okay, so the last component of your BPP is your NST. So actually, guys, itong NST, kapag normal, itong breathing, fetal movement, tone, and AFV, may option kayo not to do the NST anymore. So, sometimes ang scoring mo ng BPP is over 8 instead of over 10. Pag nakita nyo na over 10, yung inyong BPP score, it means na gumawa ng NST or the patient underwent NST. Okay? So, yung NST, ito ay depende actually sa AOG ng patient. Later on, I will teach you. So, greater than or equal to 2 accelerations of greater than or equal to 15 beats per minute for greater than or equal to 15 seconds within 20 to 40 minutes. So kapag hindi mo na-achieve itong 2 accelerations na to within 20 minutes, you are free to extend the trace to 40 minutes. So ayun, essentially guys, ito yung mga titingnan ninyo sa BPP kay Batman. Breathing, amniotic fluid volume, tone, movement, and NST. So kapag tinanong kayo, alin yung optional? Kapag normal naman yung other 4, it's your NST. Okay? So mamaya yung interpretation ng mga scores ng BPP natin. Okay. Ito guys, ano to? Bakit may isa pang mnemonic si Doktora? Okay. So the reason why ganito yung pagkaka-arrange ko sa components is because gusto kong i-emphasize kung alin yung unang nawawala kapag meron kang hypoxic injury or any form of injury to the baby. Unang maa-affect is your NST. Okay? The reactivity of your NST will be the first that will go away. Next that will be affected is your breathing. Next is your fetal movement. Last, si tone. So kaya may mnemonic ako na ganito. So NST, NBMT. So never break my trust. So yan yung order ng pagkawala ng each component. So kapag halimbawa nawalan ka ng NST, ibig sabihin very acute yung nawala ka ng reactivity, wala kang accelerations on your NST, then ibig sabihin very acute pa siya. So as you progress, ang last na mawawala is the tone. So isipin nyo na lang, ang patay na patient, ang patay na baby is limp. Wala siyang tone. So hindi na siya makakapag-extension, flexion, then back to extension, hindi na siya makakapag-close, open. So isipin nyo ganon, alright? Para maalala niyo siya. So never break my trust. So bakit ganito, Doktora? Bakit ganon ang nangyayari? Okay, so again, this is from our textbook on ultrasonography in OBGYN. So ang unang-una na nade-develop is your tone. So baliktad siya. Kung ano yung last na na-affect, yun yung unang nagde-develop. So it depends on the CNS center or na nade-develop during your organogenesis. So ang last is the fetal heart reactivity. All right? This is also the reason why we don't do your biophysical profiling before 28 weeks. Why? Again, kung titingnan nyo yung fetal heart reactivity, 24 to 26 weeks yan madedevelop. Technically, pwede ka namang mag-BPP, but you will not be expecting your baby to have a mature autonomic nervous system at this time. So, we do it at 28 weeks and above. Alright? So again, kung papansinin nyo, kung ano yung unang magde-develop, yun yung last na maa-affect in your hypoxia cascade. Alright? Okay, so never break my trust because unang mawawala si NST, next is your breathing, next is your movement, and last na mawawala is the tone. Alright? Okay, let's move on. So ito na yung interpretation natin ng scores for your BPP. So ang gusto natin na scores ay 10 or 8. Okay? Other than that, you will be thinking of fetal asphyxia. Okay? Kung papansinin nyo, di ba sabi ko ang chronic component ng BPP is your amniotic fluid volume. So kapag meron kang decreased amniotic fluid volume, it means that you have a chronically asphyxiated fetus. Alright? Kasi di ba ang amniotic fluid volume, technically ginagawa na yan since the first trimester. Dumadami lang niya siya because nakakawiwi na yung baby around the second trimester, right? Ganun siya. So, ibig sabihin kapag yung injury mo is matagal ng hypoxic yung baby mo around the second trimester, ang resulting BPP mo will have a low or oligohydramnios, low AFV or amniotic fluid volume. So ang gusto natin is ito, 10 or 8. So again, as I told you, yung denominator natin is depende kung naggawa yung ating NST or hindi. Because we can forgo the NST if you have normal values for the rest of your BPP components. Maliwanag? Okay, let's move on. So example naman, meron naman kayong cardiotocograph sa institution ninyo. So pwede mo magawa yung NST. So sabihin sa'yo ng resident mo, okay, please hook your patient to the CTG or your cardiotocograph. So, ang gagawin nyo guys, maglalagay kayo ng dalawang sensors. So, the first one is for your uterine contractions, and you place it over the fundus because that's where the contraction would be strongest or most likely detected. And your second probe is for your fetal heart tone. So, ito yung lalagyan nyo ng KY jelly. Ito guys, huwag nyo lalagyan ng KY jelly ha, baka masira siya. So, this is hooked to a machine. So, yung machine nyo, may two components din siya, no? Yung as a part is for your fetal heart tones. That's where you will see the fetal heart rate pattern. Yung sa baba niya is for the contraction. So, I will show you now in the next slide kung ano yung itsura niya sa monitor. Okay. So, ganito siya guys. So, this upper part, this represents your fetal heart tones. And yung nasa baba, this is for your contraction. So, as you can see, non-stress test. Kaya siya non-stress test kasi wala pang stress to the baby since wala pang contraction. Alright? Kaya siya non-stress test. So, pag sinabi sa'yo ng resident mo na, kindly interpret the trace. What does this mean? So, first of all, what is a non-stress test? So your non-stress test, this is a test for the fetal condition. Okay? So ang principle behind your NST or your non-stress test is that there will be fetal heart rate acceleration in response to fetal movement. So that's a sign of a good and healthy baby. So, okay. So paano mo i-interpret yung trace? Where will you begin? Okay. So when we say interpret the trace, these are the things that we look for in your interpretation. So, i-report mo to or i-interpret mo yung trace based on these components. First is the baseline fetal heart rate. So, this is the normal baseline fetal heart rate between 110 to 160 beats per minute. Your variability should be moderate. So, yung variability, ito yung fluctuations mo no, between the highest and the lowest point of your baseline fetal heart rate. And it should be the fluctuation should be between 6 to 25 beats per minute. So later on, ipapakita ko sa inyo yung mga sample traces which show your normal interpretations, your normal findings, and yung mga abnormal din. So next part of your interpretation or next component that we look for is the deceleration. Okay? Ano yung gusto lang natin na kind of deceleration? It's your early deceleration. So mamaya papakita ko kung bakit yun yung gusto natin and ano yung itsura ng early deceleration. What we don't like are these two, your late and your variable decelerations. Your accelerations, according to the book, presence or absence of accelerations, that's okay. That shouldn't be worrisome. Baka tulog lang si baby. However, if you are looking at an NST or a non-stress test, you look for at least 2 accelerations. Alright? So, kung contractions naman, titingnan natin yung intensity, interval, and your duration. Kung gaano katagal yung isang contraction. So, mamaya papakitaan ko rin kayo how you interpret your contractions. So, for a non-stress test, since walang stress to the baby, walang contractions, ang report lang natin dito sa contractions part ay no contractions. Okay? So, ang importante sa mga components na to is dapat alam nyo kung ano yung normal. Because based on that, madali na lang mag-interpret ng mga pathologic. So first component is your baseline fetal heart rate. So as I mentioned, this is your baseline fetal heart rate. So any baseline fetal heart rate that is below 110, that is what you call fetal bradycardia. So parang sa adult lang din. So fetal bradycardia and greater than 160 na baseline fetal heart rate is fetal tachycardia naman. So, paano na-determine yung baseline fetal heart rate? So, you determine this at a minimum of 2 minutes within a 10 minutes increment. Okay? So, mamaya papakita ko sa inyo one method of determining your baseline fetal heart rate. So, Dr. paano mo nasasabi na naka 2 minutes ka na or 10 minutes ka na? Yan. Okay. Sa monitor, madali siyang ma-determine kasi may mga timestamps ka. Okay? So, for example, ito, 11 o'clock, ito yung 11:01, 11:02, and so on and so forth. So, madali siyang ma-determine on your monitor. So, paano naman pag naka-print na? Ang binigay sa'yo ng nurse or halimbawa ng isang resident, naka-print na sa CTG paper. So, this is an example of your CTG paper. So, guys, importante yung speed na piniprint yung CTG paper mo kasi mag-iiba yung interpretation mo based on the speed. So typically, ang ginagawa namin is we set it at a speed of 1 centimeter per minute. Okay? So yan yung standard natin. Bakit yan? Kasi kapag naka 1 centimeter per minute ka, pag pinrint mo siya sa paper, one big square, hindi sakto yung pagkakaano ko. Anyway, one big square is equivalent to 1 minute. Okay? Tapos isang small square is equivalent to 10 seconds. So tama naman, di ba? If you count the number of the small squares within one big square, 6 siya. So 10 seconds tong mga to. Okay? So kung halimbawa may tinitingnan ka na segment, itong 3 boxes na to, this is a 30-second trace. This is a 30-second segment of your trace. Okay? So kapag halimbawa, tinitingnan mo na yung duration or interval, kunwari, interval ng contraction mo. Kunwari, may contraction siya dito sa part na to. So, pwede mong tingnan yung peak to the next peak. So, 1, 2, 3, 4, 5. Sabihin natin 5. Kunwari lang, may contraction siya dito. So, alam mo na may contraction siya coming in every 5 minutes. Okay? So, ganon. So, what is one way of determining your baseline fetal heart rate? So, ako, ang ginagawa ko, I put an imaginary line. So, if paper yan, ipo-fold ko yung line or I will use a ruler or a makeshift ruler to draw a straight line doon sa tracing ko, sa fetal heart rate. And I will look at the numbers here. Titingnan ko kung saan siya pinaka nagpo-fall under. So, for me, my interpretation here is that the baseline fetal heart rate is mga nasa 130 to 135. So we report it in increments of 5. Okay, so ito mukhang nasa 130 to 135 siya. To me, that's my interpretation. So within normal. So most of your tracing monitors, naka-denote naman kung alin yung normal fetal heart rate mo. No? So titingnan mo dito 110 up to 160. So naka-green siya, naka-highlight yung normal fetal heart rate. Yan. So, yan yung ito yung baseline fetal heart rate ko for this trait. Okay, so ito guys, tingnan nyo. Interpret nyo kung ano yung baseline fetal heart rate nyo. So, if you draw a straight line across the entire fetal heart rate tracing, makikita nyo na tachycardic. There's fetal tachycardia. So, the baseline fetal heart rate for this patient is 165 to 170. So, ayan, wala akong actual tracing from my patients ng bradycardia kasi siguro na-CS ko na yan, nagpanic na ako yan, hindi ko na na-picturean. So anyway, this is an example of a trace with baseline fetal bradycardia, no? Kasi kung titingnan mo, obviously, 60 beats per minute, may change of baseline siya dito, oh. So, 2 minutes, tapos kapag more than 10 minutes na nag-change yung baseline mo, that's considered change of baseline. So, kunwari, ito. Siguro naka 10 minutes na siya dito. Tapos bumaba to 60 beats per minute. So, ito fetal bradycardia na to. So, we're very wary na dito sa ganitong cases, no? So, kaya wala akong trace na ganito. Okay. Sige, let's move on to the next component of your CTG, which is your variability. As I mentioned, ito yung fluctuations ng fetal heart rate pattern mo. So what we want is moderate variability. So dapat ang fluctuations mo within the baseline fetal heart rate is between 6 to 25 beats per minute. So less than that, you have a minimal variability. Greater than this, you have marked variability. Meron din tayong tinatawag na absent variability. So ito, halos wala ka nang makikitang oscillations or fluctuations. Undetectable na siya. So, Doktora, paano ba yon? Paano makikita yon? Real talk, guys, to be honest, when we look at the trace, hindi ko yan binibilang isa-isa. Okay? Mauubusan ka ng time. We just do eyeballing for your variability. And that's how we determine your moderate, minimal, marked, or absent variability. So I will be showing you several traces para makita nyo yung difference nitong different kinds of variability. Alright? Kasi kung iisa-isahin mo yan, mauubusan ka ng time. So based on Williams, ito yung itsura ng mga different kinds of variability. So as you can see, si absent, halos wala ka nang ma-detect na fluctuations. Si minimal, by eyeballing, you can estimate na less than 5 or less than 5 yung kanyang fluctuations, yung difference in fluctuations. Si moderate, this is what we want, okay? So this means na yung autonomic nervous system ng fetus mo is working very well kasi merong oscillations or fluctuations in fetal heart rate, which is what we want, okay? Pag meron kang mga ganitong fetal heart rate patterns, absent and minimal, matakot ka na. Kasi you may be dealing with a hypoxic baby. So may acidemia na yung baby na yan, kaya ganito yung kanyang fetal heart rate pattern. Okay, so another one that we don't like is your marked variability. This is also a sign of distress in your baby. So sa marked variability, masyado siyang malikot, no? Masyado malikot yung fluctuations in your baseline fetal heart rate pattern. Alright, so tingnan natin yung mga real-life examples ng mga traces na may absent, may minimal, may marked, and may moderate variability. So first, I will be showing you the trace. So, interpret nyo muna, saka ko sasabihin kung absent, minimal, moderate, or marked siya. Okay? Ready? Okay, this one. Do you think this has moderate variability? So, tingnan nyo siya. So, estimate mo lang siya. So, malikot enough ba for you yung baseline fetal heart rate pattern mo? So, yes, this trace has moderate variability. Okay? So, familiarize yourself with the trace. Ganito yung maganda. Ganito yung gusto mong trace. Okay? This is a normal variability for you. Okay, let's move on to the next trace. Ayan. So, gusto mo ba yung ganitong variability? Is this minimal? Is this moderate? Is this marked? So, obviously, dito absent, no? So, yes, this is another example of a trace with moderate variability. I hope nag-get niyo yung pattern, no, based on the traces that I show you. Okay, next. Ito, sorry, pangit yung pagkaka-picture, pero kitang-kita naman, di ba? Malikot yung baseline fetal heart rate mo. So, ayan siya. So, this is another example of a trace with moderate variability. So far, okay tayo. We're dealing with healthy fetuses here. We have good fetal well-being. Okay, so this one, moderate, ito is actually yung case natin eh. Ito yung pinapa-interpret ko sa inyo kanina. So meron ba siyang minimal, moderate, or marked? So this again has moderate variability. So far so good. All the traces that I've been showing you, maganda yung variability. Now we move on to the pathologic variabilities. So sige, para mas ma-realize nyo kung anong difference nga, ilagay natin sila side by side. So for this next patient, kung titingnan nyo yung kanyang variability, halos hindi pa naman siya straight line, no? Pero hindi na siya kasing likot na tong pattern na to. Okay? So this is an example of a trace with minimal variability. Kita nyo yung difference? Okay? From this one, na malikot yung variability mo. So by eyeballing, by your estimate, around 6 to 25 beats per minute yung difference nito dito. Okay? Pero ito kung titingnan mo, mukhang less than 5 na yung difference ng mga fluctuation. So this is a trace na may minimal variability. So i-resuscitate mo itong patient na to. Okay? Alright, next trace. Ito, how will you interpret the variability of this patient? So again, hindi siya kasing likot nito, no? Halos straight line na siya, pero meron pa rin oscillations, diba? Meron pa rin fluctuations na makikita mo. Detectable pa rin siya. So this is another trace with minimal variability. So mamaya, papakita ko sa inyo kung paano i-resuscitate, no? So what are the ways by which you could resuscitate your patient? Okay, so ito. So wala na, hindi ko na isasama yung with moderate variability. So obviously, makikita mo meron ka pa ring detectable na fluctuations. So again, for me, my interpretation for this trace is a trace with minimal variability. Na-get nyo? Ayan. So tingnan nyo, di ba? Again, ito, malikot. This is what we want. Ito, almost straight line, pero meron pa rin siyang jaggedness, okay? So meron pa rin siyang konting fluctuation. So this is a minimal variability trace. Alright, So ito naman guys, so almost undetectable na yung fluctuations here in this trace. So now, ito yung graphic representation mo ng absent variability. So this is an actual trace of a patient with absent variability. So as you can see, para na siyang straight line o wala na siyang fluctuations halos na detectable. So I want to compare this with one na may minimal variability. Sa minimal variability, hindi siya kasing likot ng moderate variability, pero meron pa rin, right? May konti ka pa rin nakikitang variability. However, dito sa absent variability, it's almost like a straight line. Wala talaga ikaw madedetect na fluctuations at all. So ito yung isang example natin ng may absent variability. For this patient, I refer this patient immediately for cesarean delivery. Kasi it means na pag ganito yung case mo, you are dealing with a very hypoxic baby. Okay, so ito naman, ano ang interpretation nyo sa trace na ito? So even without counting, pero sige, let's count. So, di ba, ang isang box ay 10 beats per minute, yung isang box na along the y-axis. So, tingnan natin ha. So, 1, 2, 3, 4, 5, 6. So, kahit hindi ko nabilangin, alam ko na more than 25 beats per minute yung galaw or yung oscillations or fluctuations ng baseline fetal heart rate mo. So, this is a trace with marked variability. Okay, so I just want to place the traces side by side with their drawings no, sa Williams. So kita nyo naman, makikita nyo yung difference, yung progression ng variability natin. So this is absent variability. This is a trace with minimal variability. Ito yung moderate. So ito yung gusto natin, si moderate variability. Ayaw din naman natin ng super nagpa-fluctuate or case ng marked variability. So I hope na appreciate nyo yung difference. So sa totoo lang talaga guys, real talk, again, hindi namin binibilang isa-isa yung mga boxes na yan, kung 6 ba yan or 25 ba yan. That's more of for your exam purposes lang. Kapag binigyan kami ng trace, we really just eyeball. We base it on the general pattern of your baseline fetal heart rate and the fluctuations that we see within the trace. Okay? Malinaw? Okay, now we move on to the next component of your tracing, which is your deceleration. So again, ano yung gusto natin? Ano lang yung normal na deceleration? That's your early deceleration. Okay, so isa-isahin natin yung kinds ng deceleration. So you have your early, you have your late, and you have your variable deceleration. Now, for your early and late, kung mapapansin nyo, no, parehas sila ng configuration. Parehas sila na U-shape. Ano ang difference ni early at ni late? Si early, yung kanyang onset at recovery is coincidental with that of your contraction. So, para siyang mirror image ng contraction mo. So, yung onset niya starts with the onset of your contraction. The nadir or the lowest point of your deceleration coincides with the peak of your contraction, and the recovery is coincidental with the recovery of your contraction or the end of your contraction. So, siya si early. Si late, kaya siya late is because naurong yung iyong deceleration, no? So, your onset comes after the onset of your contraction. The nadir of your deceleration comes after the peak of your contraction. So in the same way, your recovery comes after the end of your contraction. Okay? So ang technical definition natin is dapat yung yung iyong onset to nadir for your early and your late more than or equal to 30 seconds. So yung hindi siya abrupt, okay? So, progressive or gradual yung decrease in your fetal heart rate. So, yan, greater than or equal to 30 seconds. Okay, yan yung technical definition natin. Okay, so, ang configuration niya, as I said, more of U-shape. Alright? More of U-shape siya. Ganyan. So, what causes your deceleration? So si early deceleration, this is caused by head compression. Okay, so therefore, okay lang sa atin ito. Ang ayaw natin is si late decelerations because these are caused by your uteroplacental insufficiency. So later on, sasabihin ko bakit, no? Bakit ayaw natin yung late deceleration or what causes the late deceleration. So sa early deceleration, usually ma-observe mo siya kapag 8 centimeters to fully dilated na yung patient kasi nagde-descend na yung head into the pelvic cavity. So the early deceleration, the reason why this occurs is because of increased intracranial pressure. Okay? So because there is increased intracranial pressure because of the head descending into the pelvis, you get a vasovagal response. So ang nangyayari, nagdi-decrease yung fetal heart rate. Whereas itong late deceleration na ito, this is caused by hypoxia. Okay? So may uteroplacental insufficiency ka, so there is not enough supply to the baby. So ang nangyayari sa hypoxia ay nagkakaroon ka ng chemoreceptor-induced vasoconstriction. So after the vasoconstriction, what comes after is the hypertension. So with hypertension, this induces baroreceptor-mediated decrease in fetal heart rate. So titingnan nyo, yung cascade ng events in your late deceleration, napakadami, no? It will have to undergo chemoreceptor-induced vasoconstriction, tapos may baroreceptor-mediated pa na decrease in fetal heart rate, kaya siya na-relate. Okay? So your last kind of deceleration is your variable deceleration. So kaya siya variable kasi unlike your early and your late na depende sa timing ng iyong contractions, ang variable deceleration, wala siyang variable yung onset niya. Kaya siya variable deceleration. Pwede siya before, pwede siya during, pwede rin siya after. It doesn't matter. Ang one unique thing also about variable deceleration is abrupt. Okay, kaya in-emphasize ko siya, no? So kung gradual yung onset to nadir ng iyong late and your early deceleration, kaya siya may pagka-U-shape, si variable deceleration abrupt, biglang baba. Okay? Saka kung papansinin nyo guys, sa definitions natin, ang meron lang na definition kung gaano kababa dapat yung deceleration, di ba? Dapat at least 15 beats per minute yung ibababa niya, ay si variable deceleration. When you report your variable deceleration, you can tell your resident na, Doctoria, there are variable decelerations dipping to as low as 60 beats below baseline. You don't see the same thing, ganitong beats per baseline, below baseline for early and late. You don't need to mention that. For your variable, pwede mo siyang i-mention to your resident. And one more thing about variable deceleration, if your early and your late deceleration take on a U-shaped configuration, sa variable, since abrupt siya, less than 30 seconds from the onset of deceleration to the nadir, meron siyang V-shape. Kaya sa variable, no? V. Ayan. V-shape siya. Yun yung itsura niya. Alright? So mamaya, papakitaan ko kayo ng examples ng variable deceleration para mas ma-appreciate niyo siya. So kung si early ay dahil sa head compression, si late is because of uteroplacental insufficiency, si variable deceleration, kaya mabilis lang siya, it's because of cord compression. So pwedeng position na lang yan, itong variable deceleration, no? So kaya transient siya kasi pwedeng na-impinge lang yung cord tapos aangat ulit yung, kumbaga mag-change ulit si baby ng position. So yon, kaya siya variable, okay? Kaya mabilis yung onset to nadir niya. Unlike these two na, iba yung pathophysio or pathogenesis behind it. Okay. Alright, so I'll give you another case for this next question. What are the decelerations that you see in this trait? So I'm giving you a case of a 30-year-old multigravid patient. She's already fully dilated. So may clue ka na doon. Fully dilated na tong patient mo. So ang titingnan mo dito is yung timing ng deceleration mo. Okay? So mini-mirror ba niya yung peak ng contractions mo? Yung nadir ba is coincidental with the peak of your contractions? So yes. So this is actually a good trace. So, ibig sabihin nito, for me, kung ako yung obstetrician nito, I am not worried about this case. In fact, happy ako because this means na bumababa na yung head ko into the pelvis. Remember, she's already fully dilated. So, nasa pelvic division ka na ng labor mo. So, bumababa na siya, nagde-descend na siya. And kung titingnan mo, di ba, as I mentioned, depende siya sa onset. Yung onset ng deceleration mo, same siya sa onset ng contraction mo, no? Tapos yung nadir, same sa peak. Yung recovery, same din siya sa contractions. And nag-occur siya every time nagko-contract yung patient. So, alam mo na nagkaka-head compression dito sa point na to. So, this is a category 1 trace actually. So, okay lang tayo dito. Masaya tayo dito sa tracing na ganito. Okay. How about this one? So, obviously, no, nakasulat na dito, this is a trace with late deceleration. So, look at the onset of your deceleration. So, it happens after the onset of your contraction. U-shape siya, gradual yung kanyang onset to nadir. And it happens every after contraction also. Ibig sabihin, merong nangyayari na merong uteroplacental insufficiency tong patient na to. So your baby is hypoxic. Kaya nalilate, nade-delay yung decrease in fetal heart rate niya. Okay? So again, this is another this is another trace with late deceleration. So papansinin nyo, no, yung bawat deceleration niya, bawat contraction niya, it's accompanied by a dip in your fetal heart rate. Ayan, nakikita niyo siya. Tapos, yung pinakamababang point ng deceleration niyo occurs after the peak. So, yan. So, this is an ominous sign na meron kang hypoxic baby. So, we don't like this trace. Yan. Isa lang yung nahanap ko na actual patient ko na may late deceleration. So as you can see, may minimal variability yung baseline fetal heart rate niya. And every after contraction, for each contraction, may makikita ka na gradual decrease in your baseline fetal heart rate. And yung nadir niya, hindi siya nagko-coincide with the peak of my contraction. So for this patient, na-CS ko rin to for non-reassuring fetal status because I am worried that the baby is already hypoxic. Okay? Na ano nyo siya? I hope medyo nakikita nyo yung differences in terms of the patterns ng fetal heart rate. So ito. So kita nyo naman, no? V-shaped configuration. So ito, meron tayong deceleration dito, which are variable. So again, ano ang cause ng variable deceleration? So these are caused by transient impingement on your cord. So cord compression. So mabilis lang nagre-recover agad tong deceleration na to. Yan. So may variable deceleration tayo. Okay, so again, ito meron tayo dito mga variable decel, V-shape, abrupt ang kanyang onset to nadir, mabilis din naman yung recovery. So meron sigurong cord compression tong patient na to. Okay. So those are your kinds of deceleration. Eh, Doktora, ano po yung narinig ko sa mga residents ko na prolonged deceleration? Anong ibig sabihin nun? Okay, so hindi na siya part ng tatlong kinds of deceleration, but we give a term for this, your prolonged deceleration. When you say prolonged deceleration, your decrease in baseline fetal heart rate, ulit. Okay. Okay, so those are your three kinds of deceleration. So now, kamamaya may marinig kayong another term that uses the word deceleration. So may mga residents nagre-refer sa consultants for prolonged deceleration. So ano ba yung prolonged deceleration? So prolonged deceleration looks like this, no? So your decrease in fetal heart rate is greater than or equal to 15 beats. So ito hindi ko na kailangan bilangin, no? So from 150s naging 60 siya. So obviously that's more than 15 beats, greater than or equal to 15 beats. And dapat yung kanyang duration is more than 2 minutes. So, di ba, one big box is 1 minute. So ito more than 2 minutes siya, but it should be less than 10 minutes. Okay? So, ang duration mo dapat ng prolonged deceleration, greater than or equal to 2 minutes, pero dapat less than 10 minutes. Pag umabot kasi siya ng 10 minutes or longer, yung iyong deceleration, hindi na prolonged deceleration ang tawag doon. Ang tawag doon ay change in baseline fetal heart rate. Nag-get? Okay, so ano ba yung mga nagpo-cause ng prolonged deceleration? Pwedeng meron kang maternal hypotension, or you check your uterus, mamaya hypertonic na pala siya. So dahil sa tagal na nakakontract yung uterus mo, matagal na walang oxygen supply si baby. Kasi every time you contract, you are actually inducing a hypoxic environment to your baby. So kapag ganun, pwedeng nagkakaroon na ng fetal bradycardia because of that. So another reason na nasa book, which we rarely see in practice, is because of analgesia. So kapag after ka mag-epidural, tapos makita mo yung fetal heart rate pattern na to, prolonged deceleration, they see na it's because of your epidural anesthesia or analgesia. So usually we don't observe that. Ang mga typical findings mo when you have your prolonged deceleration, when we perform our IE, sometimes may nakalabas na pala na cord, cord prolapse na pala. Kaya pala matagal na mababa yung fetal heart rate mo. It's because the head is impinging on your umbilical cord for such a long period of time. So yun, pag cord prolapse, CS kami yan. Yun ang gagawin namin. Hindi na namin yung patatagalin ng 10 minutes, i-refer na namin yan agad for abdominal delivery. So yun yung mga instances na you see prolonged deceleration. Okay. So this is an actual patient of mine who had prolonged deceleration. So kita nyo, no, more than 15 beats yung binaba niya and more than 2 minutes yung duration ng prolonged deceleration. So when I did my internal examination to assess the possible cause of the prolonged deceleration, it's because may nag-prolapse na cord. Okay, so nag-impinge yung head on the cord, causing the prolonged deceleration. So this patient underwent cesarean section immediately. Kasi dito sa point na to, nag-rupture yung membranes ko tapos bigla nag-prolapse yung cord. Alright? So ito yung mga possible scenarios where you can have prolonged deceleration. Okay. Now we move on to the next component of your CTG tracing, which are your accelerations. So in Williams, presence or absence of acceleration considered normal siya. But again, sa NST, ang tinitingnan kasi natin is the reactivity. Kung gising ba yung baby mo. Okay? So dapat may at least 2 accelerations ka. So ano ba ang definition ng acceleration? There should be a visually apparent abrupt increase. So pag sinabi mong abrupt for all the tracing, dapat less than 30 seconds siya. Yun ang meaning ng abrupt. Ang gradual is greater than or equal to 30 seconds. Okay? So dapat abrupt yung increase ng onset to peak mo in your fetal heart rate. So depende sa AOG yung definition mo ng acceleration. If your baby is greater than or equal to 32 weeks, ang parameter natin should be greater than 15 seconds. So 15 beats per minute, 15 seconds. Okay? Tapos, less than 2 minutes from onset to return, yung acceleration mo. Siyempre, pag mas bata, mas lenient tayo sa baby, no? So, hindi naman niya kailangan ma-achieve yung 15 beats. Okay na yung 10. Okay? 10 beats per minute. At least 10 beats per minute, lasting for 10 seconds. So, again, 32 weeks and above, 15. Less than 32 weeks, 10 beats per minute, 10 seconds. 15 beats per minute, 15 seconds. Okay? Na-get? So, yun yung mga acceleration. Yun yung mga criteria mo for accelerations depending on your AOG. So, kapag meron kang 2 or more accelerations in a 20 to 40 minute race, it means that you have a reactive NST. You have an awake baby. Yun ang ibig sabihin niya. So kung papansinin nyo, kung hindi namin ma-achieve yung 2 or more accelerations within a 20-minute race, ini-extend namin to 40 minutes. So hihintayin namin gumising yung baby. Or if you notice, minsan yung mga sonologists, ay yung mga OB, they have a bell. They have a bell, no? Or nagpapa-music sila para magising yung baby. So may vibroacoustic stimulation na nagaganap. So, ang gusto namin doon is to wake the baby up so that we observe these 2 or more accelerations. And that's how we get reactive NST. Doktora, pwede po ba na, example lang ha, Doktora, pwede po ba na may 2 or more accelerations ka, pero meron ka ring decelerations na, meron kang decelerations, may parang variable decelerations na itsura, na gano'n, na configuration. Pwede po yun. Okay? So, ang tawag namin doon, reactive with abnormal features. Okay? Basta ang tinitingnan lang talaga namin is acceleration. Pwede po ba, doktora, na tachycardic yung baby pero may acceleration? Pwede pa rin yun. So, ang ginagawa naming interpretation doon, reactive NST with abnormal features, and then we mention kung ano yung abnormal feature with baseline fetal tachycardia. Okay? Nag-get? Basta si NST, reactive yung or non-reactive, that will depend on the accelerations, the presence of 2 or more accelerations. Okay? Nag-get? Sige. Okay, moving on. So, ito yung patient natin na baseline, di ba? Ito yung index case natin na tinatawag. So, let's go back to the case of OB, a 35-year-old preemie-gravid. So, I hope you agree with my interpretation, no? Pero let's break down the components of the interpretation for you. So, as you can see, wala siyang contractions. Okay? So, this is a non-stress test. Non-stress kasi wala ka pang contractions to stress the baby. So, we look at the baseline fetal heart rate first. So, ang technique natin dito, we can draw a straight line across the baseline fetal, across the fetal heart rate pattern. And you can see na 125 to 130 siya. So, we report in increments of 5. Okay? So, nasa normal naman siya. Nasa 110 to 160. Saka, ang clue mo dito, nasa loob siya ng highlighted part nung iyong CTG monitor. Next is you look at the fluctuations of your fetal heart rate. So maganda yung fluctuations niya. So we say that this has moderate variability. So normal ang kanyang variability. Meron ba siyang decelerations? Meron ba kayo nakikita dyan na suspicious na pagbaba ng fetal heart rate? Wala naman. So no deceleration. Does this patient have acceleration? So this is a 30-weeker, di ba? Yun yung case natin. So dapat at least 10 beats per minute yung i-increase mo sa fetal heart rate acceleration. So yes, meron naman. So these are your accelerations. Nakikita nyo to? Yung mga abrupt increase na yan. Yan. Ito. Yan yung mga spikes na yan. These are your accelerations. So meron tayong more than 2. So we label this patient, or sorry, this trace rather, as a reactive non-stress test. Okay, so this is a reassuring fetal heart rate pattern. So we have a healthy baby here na awake. Okay, awake. Okay, so next question, board exam question to. So same patient naman. 35-year-old, naligravid. On ultrasound, you saw that her AFI is only 2 centimeters during her 3rd trimester scan. So the following are possible causes of her condition except, so anong muna yung normal AFI? So why am I asking this question? Kasi di ba tapos na tayo dun sa NST, nandun na tayo sa isang chronic component ng BPP nyo, which is your amniotic fluid volume. So now we look at your amniotic fluid volume. Ano ba yung normal? So itong patient na to, this is a case of oligohydramnios, oligo-konti. Kapag more than the normal, polyhydramnios. So ito, bakit siya, doktora, oligohydramnios? Di ba 2 centimeters naman? Di ba sa BPP 2 centimeters? Normal po yun, di ba? Basta nasa 2 planes na perpendicular to each other. Okay, guys, look at this. Ang tinitingnan natin dito is AFI, Amniotic Fluid Index. So ano ba ang definition natin ng normal amniotic fluid volume? So, depende siya sa ini-interpret mo. We have what we call a single vertical pocket. It could also be single deepest pocket. So yung SDP or SDP, ang normal value natin is 2 to 8 centimeters. So less than this, oligo. Greater than this is polyhydramnios. Now, ang in-interpret sa atin ng sonologist is the amniotic fluid volume. So your AFI, the normal levels that we use in practice is 5 to 24. So again, less than this is oligo. So 2 centimeters lang yung sa patient natin. So she has oligohydramnios. And more than 24 is polyhydramnios. Okay? So anong difference ni FVP sa AFI? So si FVP, siya yung single. Kaya siya single, di ba? Single vertical pocket. Tapos si AFI naman, we divide the abdomen of the mother into 4 quadrants. Tapos, basically, parang kumukuha ka ng SVP for each quadrant. Tapos i-add natin siya. Kaya malaki yung component score ng AFI. Okay? Kasi yung amniotic fluid index, 4 quadrants yung ginagamit nating, values ng 4 quadrants yung ginagamit natin. Okay? So, sige. So, which of the following are possible causes of her condition? In other words, tinatanong, except. Okay. Testmanship. Okay, except. So, in other words, tinatanong niya sa'yo kung alin ang hindi cause ng oligohydramnios. Alin sa mga conditions na to ang hindi magpo-cause ng low amniotic fluid volume. Okay. So first, let's review the amniotic fluid volume regulation in late pregnancy. So this is different kapag nasa first trimester ka. So this is around the second trimester to the third trimester. Ito na yung amniotic fluid volume regulation natin. So ang important na i-note nyo dito is itong dalawang naka-red. So mainly, the component of your amniotic fluid is fetal urine. Okay? So yung greatest na contributor ng amniotic fluid volume mo. And the way that the fetus and the uteroplacental unit regulate this is through fetal swallowing. Okay? So resorption naman to. Ibig sabihin, ito yung pambawas. Ito yung nagpo-produce. Ito yung nagbabawas ng amount. Okay? Swallowing. So take note of that kasi importante siya for you to realize or for you to understand kung ano yung mga nagkukos ng oligo at ng polyhydramnios. So now let's look at the causes. So sa oligohydramnios, obviously, when you have rupture of membranes, when your membranes rupture, meron ka ng exit point for your amniotic fluid. Kaya pwede siyang bumaba sa interpretation mo or sa ultrasound mo, no? Next is uteroplacental insufficiency. So there is not enough blood flow to the baby. So wala kang masyadong nag-urinate. Okay? Kasi decrease yung renal blood flow mo. So less yung urine na mapoproduce ni baby. Remember, your amniotic fluid is mostly composed of your fetal urine. So if you have chronic uteroplacental insufficiency, it could result to oligohydramnios. So, sino yung mga nagkaka-chronic uteroplacental insufficiency? Yung pangit yung blood supply, yung pangit yung vasculature. So, sila yung mga patients with preeclampsia, patients with diabetes, yung mga may rheumatic or autoimmune disorders, sila yung mga may uteroplacental insufficiency. So, kaya di ba siya kaya siya chronic component. Ibig sabihin, matagal na hindi ganon kaganda yung supply mo to the baby, yung blood flow mo to the baby, causing the decrease in renal blood flow, causing the decreased urination, and therefore decrease in amniotic fluid. So mahaba yung cascade niya. That is why chronic component ang amniotic fluid volume. Okay, na-get? Okay, next. So as I mentioned, urine ang primary source mo ng amniotic fluid. Therefore, any congenital abnormality that will result in the ulit. This part. So again, remember na ang urine ang primary component ng amniotic fluid. Therefore, any congenital abnormality in your genitourinary tract that will produce less urine, it will cause decrease amniotic fluid production. Therefore, you have oligohydramnios. So, ano yung mga examples nun? You can have Potter syndrome, polycystic kidney disease, and there could be an obstructive component in your genitourinary system. So ano yung Potter syndrome? Yung Potter syndrome, this is a form of renal failure leading to anhydramnios, okay? So specifically, yung Potter's disease, iba siya sa syndrome, okay? Si Potter's disease is renal agenesis. Therefore, you get renal failure, which leads to no urine production at all. So meron kang baby with anhydramnios. So what happens when you don't have amniotic fluid within your uterine cavity? You get pulmonary hypoplasia. So remember, your baby also ingests or swallows your amniotic fluid. So one purpose of your amniotic fluid is that when you ingest, when the baby ingests your amniotic fluid, it fills the pulmonary tract, okay? So this leads to maturation of your pulmonary system. So kapag wala kang amniotic fluid na swallow at that goes to your alveoli, nagkakaroon ka ng pulmonary hypoplasia. Na-get? Okay, and one more component of your Potter syndrome, you can get contractures and deformations of the limb of the fetus. Why? Because imagine, wala ka ng protection around your baby. Nakakramp na siya inside your uterus because your uterine walls are already hugging the baby since walang amniotic fluid volume. So this results to your Potter syndrome. So yan. So si Potter syndrome, in other words, has oligohydramnios, and in fact, they have anhydramnios in most cases. So yan, ito yung mga possible causes mo ng oligohydramnios. Essentially, it's either pumutok na yung panubigan or you have ruptured membranes, wala kang enough blood supply, therefore less urine production, and essentially lahat to, itong mga sumunod na dito kay rupture of membranes, lahat sila ay because may decreased urine production si baby. Si rupture of membranes ang yung pinaka-importante mong unang ma-rule out, okay? So, kapag may oligohydramnios ka, you check first, baka nag-rupture na yung membranes, kaya ka naman may oligohydramnios. Okay, next we discuss the causes of polyhydramnios. So again, ano ulit yung normal values natin? 2 to 8 centimeters for your SVP, single vertical pocket, and then for your AFI, 5 to 24, okay? 5 to 24 centimeters. So for your polyhydramnios, these are your possible causes. So si maternal diabetes, bakit siya nagiging cause ng polyhydramnios? So remember, di ba, ang isa sa mga symptoms ng diabetic patients ay polyuria. So if you have a diabetic mother, you also have a diabetic baby. And this diabetic baby has polyuria. It will keep producing urine. So that is why you get polyhydramnios in cases of GDM or overt DM, yung mother. Next, it could be secondary to fetal malformations. Itong fetal malformations na to, essentially, these are fetal malformations that will cause defect in the fetal swallowing. So remember, di ba, ang primary form mo ng amniotic fluid resorption is through fetal swallowing. So kapag may baby ka na hindi magaling mag-swallow or defective yung kanyang swallowing, it will lead to polyhydramnios. Kasi wala ka ng pang-decrease or pang-regulate, pang-down-regulate ng amniotic fluid volume mo. So these can be seen in cases of neural tube defects or obstruction of the fetal alimentary tract. Ulit. Take two. Okay. So one other cause of your polyhydramnios could be fetal malformations. Specifically, fetal malformations that lead to defective fetal swallowing. Remember, ang pang-down-regulate mo or the primary form of resorption of your amniotic fluid is through fetal swallowing. So if you have a malformation that will cause a defect or decrease in fetal swallowing, you will get polyhydramnios. Hindi nababawasan yung amniotic fluid mo. So saan mo yan makikita? You could see polyhydramnios in cases of neural tube defects or obstruction of the fetal alimentary tract. So example, if you have tracheoesophageal fistula, duodenal atresia, so ito, obviously, ito na yung sagot natin dun sa tanong ko kanina. So these malformations, these are examples of your malformations that will lead to decreased or defective fetal swallowing. Next cause of fetal hydramnios, yes, hydramnios and polyhydramnios, they're the same, okay? Si polyhydramnios na isa pang cause is fetal anemia. So bakit fetal anemia? So in fetal anemia, ang compensatory mechanism mo is to increase your cardiac output. So when you increase your cardiac output, this leads to increased renal blood flow, and in the end, ang end effect niya is increased urination. Okay, so if you have an anemic baby, kailan ka nagkaka-anemic baby? So, isa sa mga na-mention ko kanina, di ba, if you have RH incompatibility, di ba, nagiging anemic yung baby because there is alloimmunization na pumapatay ng red blood cells ng baby. So, what happens after that is fetal anemia. So, yun. So, kapag may fetal anemia, this leads, the end effect of this is increased urination in the baby, leading to polyhydramnios. Okay, na-get? So essentially, kapag meron kang high output cardiac failure, if you have high cardiac output failure, you have babies with polyhydramnios. Okay, na-get? So yun yung mga causes mo ng polyhydramnios. Going back to my question, so this is a case of oligohydramnios. Ang tinatanong ng question sa inyo, alin dito ang hindi makakakos ng oligohydramnios? So Potter syndrome, yes, oligohydramnios kasi may renal agenesis, so wala na produce na urine, oligohydramnios. Okay, ruptured membranes, common sense, ito dito oligohydramnios. Uteroplacental insufficiency, same din. So, decreased renal blood flow, decreased urination, oligohydramnios. So, ang isa lang dito na hindi makakakos ng oligohydramnios, most likely is your duodenal atresia. Because instead of oligohydramnios, what you'll get is defective swallowing leading to polyhydramnios or hydramnios. Okay?